Well, thanks very much, Corey, for the introduction and the invitation to be here. I've given a lot of talks about cost effectiveness in lung cancer and healthcare generally. It's usually at the end of most conferences, usually to a mostly empty room. So it's very nice that there's a goodly number of you here at the beginning of this conference. And it perhaps says something about where we're at in our thinking about cost effectiveness and so on, that it's now reached a point where we really have to take this business seriously. Here's my disclosure sign, it's or slide, and it's pretty much the list of all your sponsors for this symposium. And it's probably appropriate to start by just putting some brackets around the topic today of lung cancer and the magnitude of the issue, which in the United States is over 220,000 individuals will be diagnosed with lung cancer this year. Canada being about the 10th the size in terms of population, will have about 26,600. These days, it's almost the same number of women as men, as women have taken up men's bad habits. The positive news is the smoking rates have been going down in North America from a lot of concerted efforts to tax cigarettes and other strategies, but we still have the problem of lung cancer occurring in individuals who quit smoking, and 50% of the cases we're seeing today are in ex-smokers, and a growing number of lung cancers in never smokers. Now, in terms of some trends, this is data from your own ICER data here in the US. In terms of incidence rates, we see a decline over several decades, as well as in terms of mortality rates are declining. But you see across the bottom panel there, the 5-year relative survival has been increasing, but still in all, it hasn't increased hugely from 11% approximately in 1975 to maybe 18, 19% in 2007. Progress, but slow progress. And in terms of a global picture, lung cancer is becoming very common globally because of the export of tobacco and everything that goes with it. And you see it now makes up 13% of all cancers globally, with huge impact in terms of life lost. In 2015, expected to be 1.6 million deaths. Look at how it increases by 2030. And in some countries like China, just astronomical increases in the numbers of lung cancers and lung cancer mortality. And the cost of smoking is huge. In the US, it's been estimated to cost about $300 billion, and a large percentage of that, $170 billion, is direct healthcare costs, not all related to lung cancer, as you'll see momentarily, but other illnesses created by lung cancer. And of course, there's a huge loss of human productivity as a consequence, and that has economic consequences. So when I started in lung oncology too long ago, lung cancer was one disease. Then Mary Matthews, looking down her microscope, divided into small cell and non-small cell, and it stayed that way for quite a while, and how we treated it didn't really move the markers very much for several decades. But now it's really multiple diseases because we have therapies that are targeted, and that has both benefits to our patients and those who have actionable targets, but also has implications for drugs and drug development and costs. And we've seen other developments that impact the cost of lung cancer, refinements in how we do surgery, some of which have actually reduced hospitalization and reduced costs. We have more conformal radiotherapy, combined modality therapy for stage 2 and 3 disease. Some of these things have added to cost, but also have improved outcomes importantly. And I don't have time to go into the cost effectiveness of all these different therapies. I really want to focus on advanced disease and new drugs. And from single regimens back in the 1970s, now we have a multiplicity of choices, and this is a slide from Natasha Lill at the Princess Margaret Hospital in a publication in 2012, showing the choices, and that's not complete. For today's practices, there are more drugs, more actionable targets, but just says things are more complex. And it's going to have an impact on costs, which were estimated back in 2010 for lung cancer to be about $12 billion in the United States, and on average about $125,000 per case. And that cost is divided over different phases of lung cancer journey, being higher during the initial phases when you're diagnosing and surgically managing or radiating patients. The continuing phase after those interventions for localized disease are not very costly. It's mostly related to follow-up and some monitoring. But the end-of-life care is where the greatest percentage of costs are, and that's primarily related to drugs. I think we all know that the costs of cancer drugs have been increasing quite dramatically. And if you go back into the 70s and 80s, things cost a few $100s per month. And as you can see from the slide, in recent times, we're now at about $10,000 per month of therapy with our new drugs. And here's some Canadian data just to show you sort of proportional increases. The NIBs, the gefetinib, afatinib, erlotinib, all around a couple of $1,000s. Pemetrexate is more expensive in the Canadian terms, Avastin higher, and then you get to the targeted therapies of an ALK inhibitor, crizotinib, and now you're $7,000 per 28-day cycle. And not yet on our market, but is in yours, ramucirumab, at even a higher price. That's what it's estimated to come into the Canadian market at. So what's driving the cost of lung cancer drugs? Well, part of it is that, as you saw from the earlier slide, where we have broken down lung cancer into many segments with targetable, actionable oncogenes, it's making lung cancer, in some respects, a rare cancer. And therefore, the development of a drug targeting a very small market is going to be more costly because the manufacturer has to recoup the cost of developing that drug. But some drugs are actually delivering a lot of value, and crizotinib is a good example of that. The substantial benefit demands a premium in terms of price, so that makes that drug more expensive. And many of the new biologics, and this will certainly apply to the immuno-oncology drugs, are more complex, they're big molecules, they're difficult to manufacture, and so there are challenges that translate into costs. But probably the fundamental driver is at the bottom of the slide. It's what the market will bear, and if the last entry got $7,000, the next entry is going to try for $8,000, and so it's been driving the prices ever higher. And are these drugs really delivering more value to our patients? Well, generally not, I would have to say, with exceptions. And this is some work from Sonia Cressman, who's a health economist in Canada and British Columbia. Recent publication in the Oncologist this year. The dotted line shows the increase in cost over time of new entries into the marketplace for the treatment of lung cancer. The solid line shows the benefit in terms of life years gained. And so prices are going up, and actually over time the benefits seem to be going down. This has been observed by Peter Bach from this city in terms of colorectal cancer as well. So, however, there are important exceptions, and this is probably part of the reason Dr. Langer put this talk on this morning, is because we have some exciting new products. And here we have Nivolumab compared to Docetaxel in advanced squamous cell carcinoma. What's interesting about the slide isn't just that the survival curves are splayed and significantly so, but it's really the emergence of a tail on that survival curve for the patients who are receiving the immuno-oncology drug, and this is similar to what we've seen with other IO drugs and also in other diseases like melanoma. Trouble is, it comes with a considerable price, and these are American prices from publicly available sources. So Nivolumab on average would be about $12,000 per month or $145,000 per year if a person was on it continuously. Pembrolizumab, even more expensive, about $16,700 per month. And there are different doses that are being evaluated in different cancers, both the 2 milligrams per kilogram, the 10 milligrams per kilogram every 2 weeks. If you were doing the 10 milligrams, if that were to be the desirable dose in lung cancer, it'd be over $83,000 per month or $1 million for a patient per year. This starts to get a bit extreme. You plot it against the Bloomberg slide that I showed earlier, just putting on the 2 milligram per kilogram dose, you see this substantial jump up. And so when you start to do a little back of the envelope modeling, and this sort of parallels for those of you who were at ASCO and heard the plenary session and Leonard Saltz talk about the costs of these drugs, he did a thought experiment applying pembrolizumab to all cancers. Here I've applied it basically to lung cancer and taken the number of lung cancer cases in the United States in 2015, looked at the percentage of the surviving over time, so adding in the prevalence cases, assuming that 25% of them didn't get any treatment because of age and comorbidities. I think it's actually higher than that, but no matter. You multiply those numbers out and consider about $200,000 worth of drug per patient, you're talking about $28 billion to treat advanced lung cancer in 1 year in your country. When you remember the slide that I showed you, currently you're spending $12 billion, or at least that was in 2010. So for one drug, we're going from $12 billion to $28 billion. So there really is a need to assess the value of new drugs and what you're getting, and how can you do that? Well, in Canada, we have been using a deliberative framework to evaluate each and every new cancer drug. And it has 4 quadrants to this deliberation: the clinical benefit, the input of patient values from patients directly in the advocacy groups, the cost effectiveness and feasibility. And you can see what we consider and discuss at the table around clinical benefit, whether there's a net clinical benefit, the gains in survival versus the toxicities of the drugs, the magnitude of it in the context of the specific disease. Patient values are what you might expect in terms of increased survival, better quality of life, less toxicity, and more choice. But cost effectiveness is an important part of our discussion. And so incremental cost effectiveness is what we evaluate. And there's a lot of issues in doing incremental cost effectiveness analysis, whether you've got an appropriate comparator, what's the economic model that's used, and a lot of this stuff is rather foreign territory for most oncologists. And I'm not going to try and drill down into the details of Markov models or partition survival models, but that's the kind of work that has to be done in order to assess cost effectiveness. And we've mapped out what we do in Canada against the new frameworks that have come from ASCO that try to evaluate the value of drugs, and the European Society of Medical Oncology. And as it relates to clinical benefit, ASCO and ESMO both look at the clinical benefit, including quality of life and the safety of the drugs, but they don't look at whether there's a need or whether there's a burden of illness to be considered. Patient values, the things I just mentioned in terms of increased survival and less toxicity and choice, aren't part of the ASCO or the ESMO framework, but they're a very important contributor to our discussions in Canada. And importantly, in ASCO and ESMO, apart from considering drug cost, there's no consideration of cost effectiveness. And finally, adoption feasibility is not really considered in either of those jurisdictions, whereas we look at how easy it is to adopt a new drug in terms of IV, chair time, scope creep, and various other factors. Now, for those of you who are not health economists in the room, and I presume that's probably all of you, when we talk about cost effectiveness, what does it really mean? We talk about a ratio, which is the incremental cost of the intervention over the incremental benefits. So there's the formula. And we talk about delta C, the change in cost, over the change in effectiveness, the delta E. And the effectiveness is measured in life years gained, and they can be adjusted for the quality of those lives. So then that's a QALY, and it's a cost utility analysis, not a cost effectiveness analysis at that point. So to be cost effectiveness, the ICER, the incremental cost effectiveness ratio, needs to be something less than what you're willing to pay. Otherwise, it can't be considered cost effective. That's sort of by definition. And if you wanted to improve the cost effectiveness of an intervention, you'd either have to reduce its cost, or the benefit would have to be greater, or you'd have to increase your budget so you're willing to pay the amount of money for it. And those are your options when you're thinking about cost effectiveness. So what's an acceptable ICER? Well, there's a good debate for you. It really varies by the jurisdiction you are in. And if you're in a poor country, then you can't afford these drugs. And so things that are costing even a few $100s a month might be considered cost ineffective. So the World Health Organization has come up with a definition of what is a reasonable upper threshold for cost effectiveness, which is 3 times the GDP, the gross domestic product per capita in the unit of monetary valuation of that country. In the UK, they have sort of landed around the 20 to 30,000 pounds per QALY. In Canada, we talk about generally $100,000 per QALY. In the US, you don't talk about it at all. And it's time you did. Because you just can't keep going on the trajectory you're going on because you're going to crash and burn. Here's a couple of examples from recent evaluations at our Pan-Canadian Oncology Drug Review, or PCODR. Afatinib as a first-line agent in advanced non-small cell lung cancer compared to pemetrexate cisplatin. You can see that the delta in cost is rather modest, just about $4,300. But the amount of benefit relative to pemetrexate cisplatin is also quite modest in terms of life years, 0.017 life years, which translates to a Incremental cost-effectiveness ratio, $25,000 per quality-adjusted life year. On the other hand, crizotinib actually adds considerably more in terms of quality-adjusted life years at a 0.131, but is more expensive at $36,000 plus, so it translates to a cost-effectiveness ratio of $285,000 per quality. And we would say that's not cost-effective in Canada. So what results when we run those numbers? A very tough negotiation with industry to drive the price down, because you only have those options: drive costs down, improve outcome, or greater willingness to pay. And in publicly funded healthcare systems, the willingness to pay is actually falling, not increasing, because of the pressure on budgets. Now, there are a lot of challenges interpreting cost-effectiveness studies, whether you have the appropriate comparator. If you're doing a delta E, is it the right comparator in the trial? Are you capturing all the costs involved, whether they're the companion diagnostics, which is going to become an increasing issue as we get into next generation sequencing and so on. Management of all the toxicities, are they included in the evaluation? How you estimate survival beyond the data of the clinical trial, time horizon for the trial. These are all factors that go into discussions of HTA. And is that really relevant to those of you sitting in this room who are probably mostly clinicians? Probably not, but it sure is from the perspective of an HTA assessment point of view. We're looking for value for money. And I think that's something we have to be conscious of. And from a payer perspective, be it the government or an insurance company, it's the willingness to pay and what the budget impact will be. And if you're an insurer, it's not necessarily the budget impact, it's your profitability as you're faced with increasingly expensive drugs. And all those are going to create resistance to access of drugs that are increasingly expensive, and that will in turn impact you because it will block physician and patient access to drugs if we don't do something about it. Now, it's particularly challenging in the context of the immuno-oncology drugs, and they pose a particular problem in an HTA perspective, because in these sort of curves that I've shown here, just showing the tail on the curve for drug A, which is the immuno-oncology drug, we'll say, and the other could be the Docetaxel from the previous slide. And when you have a long tail on the curve, what happens is you accumulate life years, and even if it's only 10% patients surviving long term, you could have a very expensive drug. In this case, we've illustrated with a cost per patient of $500,000 for a year of treatment. With the area under the curve, cumulatively over time, you drive the cost-effectiveness ratio down, and it looks very cost-effective. And you can see at 4 years at $12,000 per quality-adjusted life year. So that's a very cost-effective intervention, except at 4 years it's also costing you almost $700,000. So we have a new challenge in HTA of how do we assess drugs that actually are probably curing some people. It's a nice problem to have, but it's going to really be an important one to wrestle with, because I'm afraid that the new agents, exciting as they are really going to cause this sandcastle to come down, because the total cost to the healthcare systems, whether they're publicly funded or funded as they are in your country, are really going to break the back of those systems. And so we all have to be concerned about this issue. Now, just by way of contrast and rounding out the presentation, just throw in a couple of slides about two interventions in lung cancer that are more cost effective. One is we've modeled the National Lung Screening Trial through a cancer risk management model in Canada to see how cost effective it is. And the bottom line is it is cost effective by most people's estimations. If you just look at the 3 annual screens of the NLST, it'd be about $74,000 per quality. You can, with the modeling, you can look at different age populations, and you can look at different amounts of smoking, and you can see that you get numbers that are sort of in the similar range, a little less. But what's important at the bottom of the slide is when you link up low-dose CT screening with smoking cessation with a quit rate, as you see there, and a cost in our country of about $440, it's very cost effective to engage in low-dose CT screening at $24,000 per quality. Contrast that to some of the other ICERs that I've showed you for drugs. And the final slide for comparison purposes, you can't talk at lung cancer meetings without talking about smoking cessation. We'll hear more of that on our panel this morning. But this just looks at a number of different interventions in smoking cessation from counseling plus NRT to various drugs. And you can see that such interventions are either dominant from an economic point of view, which means they cost less and deliver more benefit, so they're a dominant strategy, or cost-effective in the range of a few $1,000s per quality-adjusted life year. So as we all are aware, I hope, from the U.S. Surgeon General's report, there are many benefits to our cancer patients of smoking cessation, and a part of my mission right now is to try and get all the cancer patients in the province of Ontario to stop smoking, and by educating physicians that this is part of quality care, but it's also extremely cost-effective care, and we all should engage in it. So, concluding, I would say lung cancer treatment is costly, and it's about to get much more so by virtue of the immuno-oncology drugs, and probably a few other interventions you're going to hear about over the course of the next 2 days. Low-dose CT screening is cost-effective, not just because the Canadians have done a modeling, but because CISNET has and others have, and they all come in a similar sort of ICER. Some of the newer anti-cancer drugs are not cost-effective by normal standards, and although the immuno-oncology drugs may be cost-effective in terms of dollars per life year saved, they will have a huge, huge budget impact and are likely to catalyze the major health system funding reform in your country and in mine. Thank you very much for your attention.